Hi guys, good evening. Good evening. Can you all see me? Can you all hear me? Hi guys. Quick feedback. Hi Bharat, good evening. Good evening. Good evening. Hi guys, good evening. So, we'll continue on the same series of the esophagus that we were discussing last week. So, we start with the motility disorders. And in the motility disorders, we spoke about achalasia cardia. We spoke about what are the various components of achalasia cardia. And then we'll discuss furthermore. So, last time when we met, we discussed about how to interpret manometry, how do you have this color combinations, what do you mean by this gap, what is the word called as IRP, what is the word called as DCI, थोड़ा और उसमें deeply आज बात करेंगे. So I will continue on the motility disorder series only. So today's motility disorder that I would like to talk about will be about diffuse esophageal spasm. So we'll talk about a very common disorder, I mean not common, but then a very interesting and important disorder called as the diffuse esophageal spasm. Diffuse esophageal spasm. Now, I hope everybody knows that the word diffuse esophageal spasm is now being replaced by the latest classification, right? We have the Chicago's classification, which deals with the motility disorders. So, I hope everybody knows the update, but as uh, the guy who is supposed to give you the update, I take the responsibility of telling you that we have the latest version of the Chicago classification, and the Chicago classification, according to the version 3.0, right? The third version of the Chicago classification has renamed the diffuse esophageal spasm into distal esophageal spasm, into a distal esophageal, into a distal esophageal spasm, right? So the whole objective of diffuse esophageal spasm is now rebranded, or I can say it is renamed as the distal esophageal spasm. Okay. Now let's try to understand what is the objective behind it. Remember, when you talk about the distal esophageal spasm or a diffuse esophageal spasm, the concept or the pathophysiology for the diffuse esophageal spasm. When I talk about what is the pathophysiology, see, to be very honest, it is very poorly understood, but what we know that it is associated with something called as right hand side is the mnemonic, right? So what happens in diffuse esophageal spasm? We have RHS problem. Now what is RHS? There is repetitive high amplitude. There is repetitive high amplitude simultaneous contractions. Esophageal contraction, right? So we say there is a repetitive high amplitude simultaneous esophageal contraction is what results in diffuse esophageal spasm. So if we try to understand the way we've been trying to understand the whole disorders, like normally when we say, if you take this as the representation of the esophagus, now we always told you that whenever the food comes, the part where the food comes, that part of the esophagus is going to contract. Distal to that part is going to distend, and the rest of the esophagus will remain in a collapsed state. And this is what we told you, right? So every time the food is going to come, the part where the food is going to come, that part is going to contract, right? Distal to that, there will be relaxation so that the food can accommodate, and this is what we call it as the primary wave of contraction. And when this recoils back, when this recoil occurs, when the food moves forward, this is what we call it as a secondary contraction, so that the food goes forward, right? We have dealt with this, right? Every time the food comes, that part contracts, distal dilates, food goes back in, so contracted part reverts back, so the distended part recoils back. Now when it recoils back, it also generates a little amount of pressure, and that little amount of pressure is what we call it a secondary contraction. So until this, it is normal. Now imagine if the food comes into the part of the esophagus. Now this is the part of the esophagus. Now let's say this is the esophagus that we are talking about, right? Now imagine if the food comes at this part of the esophagus, rather than going in a like a synchronized fashion, that primary, secondary, primary, like an alternate wave of contraction. If there is a simultaneous wave, that means the entire esophagus now goes into a contractive state. It now goes into a contractive state. So rather than only the part of the esophagus which is having the food contracting, you see the entire esophagus, or at least a part of the esophagus wherever the food is present. Usually it happens on the distal body of the esophagus. The entire esophagus goes into contraction. Now, if the entire esophagus goes into contraction, do you think the food can move forward? Now, there is no rocket science in this. Because of this, the food cannot move any further, right? Because of this, the food cannot move any further. So, what is going to happen? Now, because of all the components, the entire esophagus going into contraction, this occurs repeatedly. So, it is repeated or repetitive high amplitude simultaneous contraction will now result in the esophagus to become completely contracted and then goes into spasm. So obviously if this is going to happen, will the food move forward or not? The answer is no. So it is a non-progressive contraction. This is a non-progressive contraction, right? Yeah. So this is what we call it as a non-progressive contraction. And obviously because the entire esophagus goes into contracted and remains in a contracted state, it will also get into spasm, hence mimicking pain and all that component. So this is the basic concept behind a diffuse esophageal spasm that you're going to look across here. Now let's say if the patient experiences this, how would a patient would present to us, right? Now in terms of clinical presentation, remember it is more common in females when compared to males. In fact, it is 5 times less common. It is 5 times less common than achalasia cardia. So achalasia cardia is a more common motility disorder when compared to diffuse esophageal spasm, right? Now, when you talk about the whole concept of this, okay, another thing that I can add up in the pathophysiology only is when you look at the esophagus per se. Now, what are the findings that you can see? Now, because of this repeated contraction, it remains in a contracted state. Obviously, the muscle is going to get bulkier. It is going to become more spastic. So, here you will see presence of muscular hypertrophy. There's presence of esophageal muscular hypertrophy with branches of vagus nerve. With branches of vagus nerve undergoing degeneration, or is going to get damaged, right? There will be degeneration. The branch of vagus nerve degeneration is noticed. So obviously the motor supply will go because vagus is going to supply that, and obviously the muscle is going to become bulkier. Bulkier muscle, no motor supply. Obviously the peristalsis is going to get hit. Right now, this is usually seen in the lower one third of the esophagus. It is usually seen in the lower one third of the esophagus. This is usually seen in the lower one third of the esophagus, right? Now, let's say how does the patient present to us in terms of clinical features. So, it's more common in females. You'll say it is 5 times less common compared to achalasia cardia. And if you look at the trigger factors, when you look at the trigger factor, now see it is more common in females. Now, any female per se, what are the trigger factors when they get triggered off? Obviously, when there is a lot of emotional stress, right? So it is the emotional stress. It is the emotional stress that can trigger. And second, whenever they're consuming cold liquids, right? Whenever they come consuming cold liquids, right? So all the females down there, when you're going through an emotional stress, drink something warm, right? Don't go with cold fluids, right? Now, that's why, if you're anticipating a breakup, don't go for a cold coffee, always pick a hot coffee, right? So, emotional stress and cold liquids are the trigger factors that can result in diffuse esophageal spasm, or I can say symptoms of diffuse esophageal spasm. Now, once the symptoms kicks in, what is going to happen? Now, the patient will experience, because the entire esophagus goes into spasm and this occurs during swallowing, there will be sudden severe onset of chest pain. There is sudden severe onset of retrosternal. There's retrosternal chest pain. When you talk about this pain radiates. This pain radiates to jaw and shoulder. That is jaw, arm, and shoulder. Now imagine a patient who is having a pain which is starting in the chest region and radiating to the limb, jaw and shoulder. You'll always think in terms of angina. So because it is also so severe in component, it appears so severe that mimics almost like angina. So this is also given a nickname of esophageal angina, also referred to as esophageal angina. Now, because the entire esophagus is in spasm, the patient cannot swallow anything. So, hence there will be dysphagia. Now, when you talk about dysphagia, we know our questionnaire here. Dysphagia will be for both solids and liquids. Because the entire esophagus goes into spasm, dysphagia will be equal for both solids and liquids. And you see, because there are no peristalsis, and entire esophagus goes into spasm at the same time, the intensity does not change much, so it is non-progressive. So the dysphagia and diffuse esophageal spasm is going to be for both solids and liquids. It remains equal for both solids and liquids, and this is going to be a non-progressive dysphagia. This is going to be a non-progressive dysphagia, right? So here the patient is going to have sudden severe onset of chest pain, and pain radiates to the arm, jaw and shoulder, and patient experiences dysphagia, and this occurs on a repeated basis. Now, because the patient is having dysphagia, I would like to evaluate. So, we will call the patient for investigations. We look the patient for investigations, right? Now, when we talk about the investigations, because of dysphagia, the first investigation, I would like to do a barium swallow. So, when you perform barium swallow, what are we going to get? In the barium swallow, these are the images. In the barium swallow, now as we go ahead with barium swallow, these are the images that you will see for barium swallow. I'll give you a couple of images so that you can understand it with a greater relevance points that we're trying to discuss here, right? So what are the two findings that you can see here? Okay, so when you talk about in the barium swallow, the first finding will be something like this, right? Now if you look at this particular finding, it appears like a something which is like this, right? Seen this, right? It appears as if you're going to open a bottle of wine, and this is what we call it as the corkscrew sign. This is what we call it as a corkscrew sign in a diffuse esophageal spasm, right? Now, on the other hand, the other descriptive findings that they can tell you, that now because it appears like a wave, this is also called as the rosary bed appearance. It's also called as the rosary bed appearance. This also looks like a diverticulum, like an outpouching, but these are pseudo ones. So this is what we call it as the pseudo diverticulum. They're also called as pseudo diverticulum. And you see that like multiple beads which are now connected with a string. So this is like string of beads appearance. The string of beads, right? So you have the corkscrew appearance, you have the rosary bed appearance, you have the pseudo diverticulum, the string of bead appearance. All these are the radiographic images that you're going to see on a barium swallow. Right. Now, again, as I told you, for motility disorders, barium swallow cannot be the investigation of choice. or to conclude the diagnosis, you need to go ahead with a high resolution. You have to go at high resolution manometry. You have to go ahead with high resolution manometry. Now, in a high resolution manometry, this is how a diffuse esophageal spasm or a distal esophageal spasm would actually look like, right? So this is the manometric image. This is the manometric image of your distal esophageal spasm. This is how the distal esophageal spasm. Now, before you interpret it, we have already understood the basic objective behind it. If the color is towards red, that means the pressure is high. If the color is towards blue, that means the pressure is low. As simple as that. This is the first thing that you know. When you see the interpretation on a manometry, you need to know the color code. If it is red, the greater or the darker the shade of red, more pressure. Blue means lower pressure. I mean, if it is even more lesser, if the shade of the blue is even more lighter, the pressure is even more light. Now, we have to measure something called as, like, we have various components we measure, which is integrated relaxation pressure. Then you have something called as distal contractile integral, and there is something called as DL, that is distal latency, right? Integrated relaxation pressure, DCI, DL are the components that we are going to measure. Now, we have already dealt before also, but just to understand or make you understand what do you mean by these terminologies, I'm just going to add another image so that you understand better. Now, this is what we need to understand to get an interpretation of what we are trying to sell. Now, when you look at this entire component, from the swallow, that is from the transition zone, from this point to this point where the lower esophageal sphincter is getting relaxed, the entire pressure that you measure is what we call it as DCI, that is a distal contractile integral. Now, from the time the upper esophageal sphincter relaxes to the swallowing point, from the upper esophageal sphincter that is relaxing to the lower esophageal sphincter that is relaxing, this entire phase, when you look at from here to here, that latency is what we call it as the distal latency. That means it started, the swallow started here and the swallow ended here. So the time frame between start and end is what we call it as distal latency. So you need to know that what are the normal values that you have. If an IRP is less than 15, it is normal. If the distal latency is more than 4.5 seconds, it is normal. And if the DCI is between 450 to 8000, it is considered normal. This is what you need to have in your mind. Okay, nothing more. These are the values that they will tell you, that an IRP of less than 15 is normal, distal latency of more than 4.5 seconds is normal, and distal contractile integral between 450 to 8000 millimeters of mercury is considered to be normal, right? So when I say that a patient is having a distal esophageal spasm, you can see that this area, where we're calling it a DCI, from this point to this point, this is what we call it as the distal contractile integral. Now the whole point from here to here is in red, so obviously the pressure is very, very high. So if you get something like this, such a red color, it is going to be a distal esophageal spasm. Now, in order to call a distal esophageal spasm, the criteria is that the DCI should be more than 450 millimeters of mercury, right? I'll just put it here. Now, in order to call the distal esophageal spasm, for a distal esophageal spasm, remember the distal contractile integral, the DCI, should be more than 450 millimeters of mercury. The DCI should be more than 450 millimeters of mercury. Yeah, 1 second. Yeah. As I was saying, the DCI should be of more than 450 millimeters of mercury, right? Now, along with that, because again, when we say the DCI 450 to 8000 is normal, more than 450 is considered to be, with the symptoms that we have, will be considered to be as distal esophageal spasm. But along with that, Along with that, you have more than or equal to 20% premature contractions. And more importantly, the integrated relaxation pressure should be less than 15 millimeters of mercury, right? So what you have it for distal esophageal spasm. For a distal esophageal spasm, there are three criteria. Number one, the DCI should be more than 450. There should be more than equal to 20% premature contractions, and IRP should be normal. Okay. If the IRP is more than 15, it is going to be achalasia cardia spectrum, right? If the IRP is normal, more than equal to 20% premature contraction, or DCF more than 450, this is going to be your distal esophageal spasm. Now the same thing, same symptoms, but this time when I say if the DCI is more than 8,000 millimeters of mercury, it is going to be 8,000 millimeters of mercury per second per centimeter. So it is like, obviously you're looking the entire flow as well. So this is the value that we have. Okay. Now in that context, this is what we call it as the nutcracker esophagus. This is what we call as the nutcracker esophagus, or also referred to as the jackhammer esophagus. Also referred to as a jackhammer esophagus. So we simply say that the nutcracker esophagus is a severe form of distal esophageal spasm. It is a severe form of the distal esophageal spasm, right? So this is the interpretation that you need to have for a high resolution manometry when you are looking at distal esophageal spasm. Okay. Now the management protocols are going to be same as your achalasia cardia. Then look at the management, the first line management. The first line management will give calcium channel blockers, we will give nitrates, we'll give injections of botulinum toxin. All these could be tried. If this fails, we'll switch to second line management, and the second line management is going to be long esophageal myotomy. Long esophageal myotomy with anterior partial fundoplication. With anterior partial fundoplication. So we have already discussed this in our achalasia cardia, but just for the sake of understanding, if I have to be clear, for a long esophageal myotomy, so if you take this as a representation of the cricopharynx, this happens to be the esophagus, and let's say this happens to be the stomach. Right. Now let's say that this is the entire extent of the esophagus. The entire extent of the esophagus, let's say it's here. Right. So when we say long esophageal myotomy, we are going to excise it from all the way to the cricopharynx to the cardia of the stomach, right? So the whole myotomy is done here. Now once the myotomy is done, obviously the lower esophageal sphincter is going to get compromised. That can result in GERD. To prevent that, I'm going to take the fundus of the stomach and do a anterior fundoplication. Do an anterior fundoplication. Do an anterior, so we'll take the fundus and then do a wrap on this, and this is what we call it as the anterior fundoplication, like a patch. So this is the patch of the stomach where we have secured it. So this is your anterior fundoplication. Right? So taking the patch of the stomach and you've just labeled it across. So taking the fundus of the stomach, labeled it, right? This is what we call as long esophageal myotomy with anterior fundoplication. The same context you can also do with the same technique with poem also, that we have already discussed it, per oral endoscopic myotomy. The same thing you can do with endoscope also, which is called as a per oral endoscopic myotomy. Same, the extent of myotomy remains the same. Okay? So now if you have a patient of diffuse esophageal spasm or a distal esophageal spasm, you now know how to categorize it, understand it, and then diagnose and treat it as well. Now the most important thing that you need to know is going to be this, right? So how do you interpret our manometric findings with respect to your distal esophageal spasm? With respect to our distal esophageal spasm. Sorted? Clear? Is everybody clear? Is everybody clear? Quick feedback. Clear? Can we move on? Sure. All right. So continuing the lesser common ones which you would have not, seen much often. Okay, we'll be talking about lesser common disorder. In the motility disorders only, the lesser common disorder is what we call as the hypertensive lower esophageal sphincter. There's something called as the hypertensive. We have the hypertensive lower esophageal sphincter. It is the hypertensive. It is the hypertensive lower esophageal sphincter. Now, again, this is an old term. The new term according to the Chicago classification. The new term according to the Chicago classification is what we call it as the esophagogastric junction obstruction. So now we call it as the EJ obstruction. This is now what we call it as the EJ obstruction. That is going to be according to the Chicago's classification. Now, when you look at the hypertensive lower esophageal sphincter, now what do you mean by this is when you take this as a representation of the esophagus, and let's say this is the lower part of the esophagus, and then you have the stomach which is present here. Now we're saying that this part of the esophagus, which is the lower esophageal sphincter which is present. Now, you remember in achalasia cardia, what was happening? There's loss of peristalsis, hence the tone was increased, right? There's loss of peristalsis, hence the tone was increased, so the food was not able to pass. Here, we don't know the exact pathophysiology, but we find when the food comes, here the sphincter becomes more tense. I'm not saying there's no peristalsis. Here, the lower part of the esophagus will have peristalsis, but the tone increases. So we know that the tone of the lower esophageal sphincter is going to increase tremendously here. Now, obviously, when the tone is going to increase, this is going to result in dysphagia as it was happening in achalasia cardia. Now, anywhere in the dysphagia, we have the same questionnaire that we have to follow, right? Now, what is the question that you have? Is it dysphagia for solids, liquids, or both? Now, because this is going to be increased tone, the tone is increased, like we have it in achalasia cardia. I'll tell you the difference precisely, but the symptoms remain the same. So, is the dysphagia here is going to be for both solids and liquids. It is going to be solids and liquids. When it comes down to dysphagia, which is more, remember here also the dysphagia will be more for liquids when compared to solids, because the tone has to be, or the sphincter has to be opened by exerting pressure, and this is also in a progressive manner. This is also in a progressive manner. What is going to be a difference? Along with the increase in the tone in the lower esophageal sphincter, there is presence of effective peristalsis. There is presence of effective peristalsis in lower esophageal segment, right? So you will see it is almost like achalasia cardia, but in achalasia cardia, if you look at, if I give you the note point to be remembered, what is the difference in achalasia cardia, right? Now when it comes down to the achalasia cardia, if I give you an achalasia cardia, when you look at the achalasia cardia, the first thing you will notice that there will be increase in the tone. There will be increase in the tone of lower esophageal sphincter with absence of peristalsis. With absence of peristalsis. There's absence of peristalsis in lower esophageal segment. That's the first difference. Okay. तन्मय आपको क्या नहीं समझ में आया, मैं सिंपली समझा देता हूँ. देखो, ये जो आपका डिसऑर्डर है, द हाइपरटेंसिव लोअर इसोफेजियल स्फिंक्टर, ये ऑलमोस्ट अक्लेशिया कार्डिया की तरह है. ठीक है. अब फर्क ये है कि इसमें जो हाइपरटेंसिव लोअर इसोफेजियल स्फिंक्टर है, आप देखोगे जैसे अक्लेशिया कार्डिया में लोअर इसोफेजियल स्फिंक्टर का टोन बड़ा होता है, यहाँ पे भी टोन ज्यादा है, टोन इज हाई. इट अपीयर्स टू बी अक्लेशिया कार्डिया. लेकिन जब आप इसको व्हेन यू इवैल्यूएट दिस कंडीशन, आप देखोगे कि यहाँ पे लोअर पार्ट में इन दिस पार्ट ऑफ द esophagus, दैट इज लोअर esophageal segment, पेरिस्टालिसिस इज आल्सो प्रेजेंट व्हिच इज इफेक्टिव. तो अक्लेशिया कार्डिया में तो बेटा पेरिस्टालिसिस नहीं होता ना, तो दैट्स द डिफरेंस बिटवीन दीस टू. आई टेल यू, ऐसे स्टोरी बनेगी ना तो पूरी स्टोरी सुन लेना, समझ में आ जाएगा. अभी के लिए याद रखना कि अक्लेशिया कार्डिया में इंक्रीज टोन विद एब्सेंट पेरिस्टालिसिस होता है और हाइपरटेंसिव esophageal sphincter में इंक्रीज टोन with presence of effective peristalsis होता है. Now when you talk about the triad of the ecclesia cardia, I hope everybody knows it. I did not discuss it as triad. लेकिन if I give you the triad of the ecclesia cardia, the triad of the ecclesia cardia is dysphagia, there is regurgitation of food particles, there is regurgitation of food particles, and weight loss. And weight loss, right? So there's presence of dysphagia, there's presence of regurgitation and associated weight loss. This is what we call it as the triad of the ecclesia cardia. This is the triad of the ecclesia cardia, right? Now obviously क्योंकि यहाँ पे patient आया dysphagia के साथ, I will do HRM, that is high resolution manometry. You will do presence of, or do a high resolution manometry, right? Now high resolution manometry, when you do it, this will also have an integrated relaxation pressure of more than 15 millimeters of mercury, right? Now when you look at the IRP of more than 15, I know the IRP of more than 15 is also seen in ecclesia cardia. So what I'll do is, once the IRP is of more than 15, then on the manometry I will evaluate the peristalsis, right? So there is presence of peristalsis. There is presence of peristalsis and there is absence of peristalsis. If there is presence of peristalsis, then you would simply call this, this you'll call as hypertensive, or I can say EGJ, esophagogastric junction obstruction, or in simple words, hypertensive lower esophageal sphincter. Hypertensive lower esophageal sphincter. If there is absence of peristalsis, then we would call this as achalasia cardia. Call this as achalasia cardia. देखो ये almost लग achalasia cardia की तरह है, तो this is also recognized as achalasia cardia in evolution. This is also known as achalasia cardia in evolution. It is achalasia cardia in evolution. Okay. Now, how do you interpret the whole disorder that we have spoken across? Now, you will have a patient who presents to you with the features similar to that of achalasia cardia. You'll have the patient who present to you with features similar to that of achalasia cardia. Now, because you have achalasia cardia, when you do a barium swallow, the findings are not that great. But yes, because the tone is here high, you will see some amount of narrowing is there. I will do the manometry. The first thing I will going to do or measure is IRP, that is integrated relaxation pressure. Now, I'll get an IRP of more than 15. Now, the minute I get IRP of more than 15, I know patient is having achalasia cardia. But in the manometry, I will evaluate for peristalsis. Agar peristalsis absent hai, then the answer is going to be achalasia cardia. If there is presence of peristalsis, then you call it as EJJ obstruction or hypertensive lower esophageal sphincter. Somebody is saying, sir, what is EJJ? Esophagogastric junction obstruction, EGJ. Okay? It is your EGJ, that is your esophagogastric junction obstruction. Clear? Sorted. So this is how you differentiate between the achalasia cardia and the hypertensive lower esophageal sphincter. Another lesser known disorder which nobody talks to us in our medical school also, because they think it is not important, but we think every single disorder deserves a mention, right? So there's another disorder which is called as an ineffective esophageal motility. There's something called as ineffective esophageal motility. So something called as the ineffective esophageal motility. So let's try to understand what is this ineffective esophageal motility, right? Now, when you talk about the ineffective esophageal motility, we'll try to understand in our own style, right? Okay. So when I say ineffective esophageal motility, it happens because, or I can say it is as a risk factor, it is secondary to gastroesophageal reflux disease. So it so happens, let's say this happens to be the esophagus and this happens to be the stomach. Now what is going to happen is, every time there is the reflux of the gastric content in a GRD, when a patient develops gastroesophageal reflux disease, you see the gastric content is now going to reflux into the esophagus. Now, as it refluxes into the esophagus, because it's an acid, obviously when the acid falls onto the esophageal wall, I can say there will be some amount of damage, there will be some amount of injury onto the esophageal wall. Now, if the damage in the esophageal wall becomes significant, right? So, I can say in the GRD, there is reflux of gastric content. There is the reflux of gastric content into the esophagus. Now, if it is unchallenged, or let's say patient does not seek any medical attention, what is going to happen? It is going to cause damage of the esophageal wall. It will result injury in the esophageal wall. Now, if this injury gets extensive, obviously it will hamper the motility of the esophageal wall. So, say it decrease in the motility of the lower esophagus. Now, let's understand the problem. Now, if the motility of the lower esophagus is going to get hampered, now let's say there is some amount of gastric content that is refluxed and which is now present here. So, there is a gastric content that is getting accumulated here. Obviously, the lower part of the esophagus is going to be in a collapsed state because of the sphincter mechanism. I'm not saying it is going to be strong, but even a small weak sphincter will remain closed. Now, in order for these content to push back into the stomach, whatever has gone into the esophagus, it has to come back into the stomach. For that, the esophageal contractility should be present. Now, in this patient, the wall is getting damaged, so the contractility is getting hampered. If the contractility is getting hampered, the content cannot pass back into the stomach, so there is stasis of content. Now, if this stasis of content, this gastric content is rich in acid, it will cause more damage onto the wall. So, if there is decrease in the motility of the esophagus, now this will result in decreased acid clearance or a reduced acid clearance, causing severe injury to the wall, severe irreversible injury to the esophageal wall, injury to the esophageal wall. right? So this, when there is an injury, obviously the motility is getting hampered, and this is what we call it as the ineffective esophageal motility. Now, whenever a patient experiences this, obviously I want to know whether the wall is injured or not. So I'll take the patient for high resolution manometry. So we'll get an HRM done here. In a high resolution manometry, what do you get? Now, as I told you, the distal contractile integral. So the normal DCI, the normal distal contractile integral will be between 450 to 8000 millimeters of mercury. So the patient who is having ineffective esophageal motility, called as those who are having ineffective esophageal motility. Obviously, the pressure will not be generated. So the distal contractile integral will be less than 450 millimeters of mercury. Along with that, you will also notice more than or equal to 50% will have ineffective swallow. Will be ineffective swallow because there is no peristalsis. Now, because it is irreversible, the management is quite tricky here. When you say what is the management here, we say treat GERD and symptomatic management. Even the surgical options are not great, so we'll just simply resort to the symptomatic management. If it is too extensive, you can go ahead with the resection and anastomosis, but then that's for the last resort. Usually we say treat the GERD and do a symptomatic management and hope your patient gets better at this, right? So this is about your ineffective esophageal motility. So we have covered all the motility disorders that exist in our Chicago classification. Now, when I say Chicago classification, that means every single component that is present. Now, I've been telling the Chicago, Chicago, Chicago. What is the Chicago? ये भी देख लेते हैं, ठीक है? Normally, we teach Chicago classification to the residents of general surgery, but now you're no less if you're indulging into such extensive lectures. If you want to read completely, let's do it because Chicago classification is there in Bailey and Love as well. So we'll talk about the Chicago classification. We have the Chicago classification of the esophageal motility. This is for esophageal motility disorder. So I'm going to tell you the latest version that we have, that is version 3.0. Right? Yeah, everything is now so much into version like 1.0, 2.0, 3.0. So why not our motility disorders? So Chicago classification, the latest version that you have is the version 3.0. Right? Now, according to your Chicago classification, we have type 1 achalasia cardia. We have the type 1 achalasia cardia. Now, the type 1 achalasia cardia is what we call it as the classical achalasia cardia. The criteria to call this is going to be an integrated relaxation pressure of more than 15 millimeters of mercury, which we have already told you, right? IRP of more than 15, then you will say that there is 100% failed peristalsis. Now, how do you know the 100% failed peristalsis? The criteria for 100% failed peristalsis is a distal contractile integral of less than 100 millimeters of mercury. If a DCI, how do you know it's a 100% failed peristalsis? You will measure the distal contractile integral. If it is less than 100 millimeters of mercury, then I will say it is 100% failed peristalsis. It is 100% failed peristalsis, right? Along with that, there will be presence of premature contractions. There will be presence of premature contraction. And this is your achalasia type 1. We have already dealt with this, right? Then we have achalasia type 2. So type 2 achalasia cardia. So when I say type 2 achalasia cardia, this is what we call it as the spastic variety. Now, in order to call achalasia cardia, I told you the integrated relaxation pressure has to be more than 15 millimeters of mercury. So that is going to be satisfied. Second, there will be no peristalsis, there will be 100% failed peristalsis. Okay, wait. Type 2 is not spastic, type 3 is spastic. Type 2 is going to be compressive. Panesophageal pressurization, it is compressive. Type 3 is spastic, sorry. So it still remains the same. IRP of more than 15 millimeters of mercury, there is 100% failed peristalsis. There is 100% failed peristalsis and associated with pan-esophageal pressurization. With pan-esophageal pressurization, which we have already told you. I've already shown you before. Okay? So in type 1, you have IRP of more than 15, 100% failed peristalsis with premature contraction. Same here, but there is pan-esophageal pressurization. Then you have something called as the type 3 achalasia cardia. You have type 3 achalasia cardia. Now this is what we call it as a spastic achalasia cardia. Again, here IRP of more than 15 to call this as achalasia cardia, right? Along with that, there is presence of spastic contractions. The presence of spastic contraction. How do you know there is a spastic contraction? Remember here the distal contractile integral will be more than 450 millimeters of mercury. There will be more than 450 millimeters of mercury. This is your type 1, type 2 and type 3 achalasia cardio, right? Now, as we said, another one which we just learned, that is EOJ obstruction, that is esophagogastric junction obstruction. It's also called as achalasia in evolution. Achalasia in evolution. So here again, the IRP is going to be more than of 15 millimeters of mercury. IRP is more than of 15 millimeters of mercury, but there is presence of peristalsis. There is presence of peristalsis, right? So according to the Chicago classification, this is the first set, and this is what we call it as the achalasia-like presentation. Then you have the major peristaltic disorders. Then we have the major peristaltic disorders. So when you talk about the major peristaltic disorders, for the major peristaltic disorders, what are the criteria that you have? The number one, we have absent contractility. We have absent contractility, distal esophageal spasm, and nutcracker esophagus. And the nutcracker esophagus. So there are three components that you should know. Now, when you talk about the following components, about the absent contractility, remember you will have an integrated relaxation pressure of less than 15 millimeters of mercury, but 100% failed peristalsis. 100% failed peristalsis. There is 100% failed peristalsis. Now, when you talk about the diffuse or a distal esophageal spasm, here the distal contractile integral is more than 450 millimeters of mercury with more than or equal to 20% of premature contractions. Now here, if a distal contractile integral is of more than 8,000 millimeters of mercury, then it is going to be your nutcracker esophagus, right? So this is about your major peristaltic disorder, right? The last set that you have is about the ineffective or the minor peristaltic disorders. Minor peristaltic. disorder. So, we'll talk about the minor peristaltic disorder. Let's conclude that as well. In a minor peristaltic disorder, you will have ineffective esophageal motility. You have ineffective esophageal motility. Now, this ineffective esophageal motility should be seen in more than or equal to 50% of ineffective swallow. There's an ineffective esophageal motility. Then you have something called as the fragmented peristalsis. Fragmented peristalsis. Now, in a fragmented peristalsis, you will see more than or equal to 50% of fragmented contractions, with distal contractile integral of more than 450 millimeters of mercury. Okay. Now, such an extensive table is what is your Chicago classification is. Everything that we try to understand in the motility disorders, the Chicago classification is given the criteria. So, when do you call it the type 1 eclasia? The type 1 eclasia, in order to call as eclasia cardia, if I give you a quick recap, in order to call a disorder to be eclasia cardia, the most important prerequisite that you need to follow is going to be an IRP of more than 15. You need to follow that the integrated relaxation pressure should be of more than 15, no matter whatever it is. Now, if it is classical, you will say there is premature contraction. If it is going to be compressive, there is pan-esophageal pressurization. If it is spastic, then there is a spastic contraction or DCF more than 450. This is what you need to know if you're talking about eclasia type 1, type 2, type 3. EOG obstruction is again IRP of more than 15, but presence of peristalsis. For diffuse esophageal spasm, DCF more than 450. For nutcracker, DCF more than 8000. Ineffective esophageal motility more than 50%. Ineffective swallow for fragmented peristalsis more than 50% fragmented with DCF more than 450. Right? If you know all this, this is what you should know with respect to our Chicago classification. That's it. Nothing more than that. Clear? Now, to make your life a little bit more challenging for eclasia cardia only, in eclasia cardia, for the symptomatic presentation, we have a clinical scoring system for eclasia cardia. So, quickly looking at the clinical scoring system used in eclasia cardia. A clinical scoring system used in eclasia cardia. This is mentioned in our Bailey and Love also. So it becomes absolutely important for us to discuss here as well. Now, this is what we call it as the Eckardt score. So, Eckardt score is the clinical scoring for eclasia cardia. It's a clinical scoring for the eclasia cardia. So, what you do is on one end, I will put score and then I will give you the symptoms, right? So, the symptoms that you have is of weight loss. It is the weight loss, dysphagia, retrosternal pain, retrosternal pain, retrosternal pain, and regurgitation. Retrosternal pain and regurgitation, right? So, when look at this, let's look at the scoring components as well. So, we have a score of 0, a score of 1, a score of 2, and a score of 3 is given. If the weight loss is going to be none, a score of 0. If it is less than 5% weight loss, score of 1. If it is 5 to 10% weight loss, score of 2. More than 10%, a score of 3 is given. Dysphagia, if it is absent, that is none, a score of 0. Occasionally, a score of 1. Occasionally, a score of 1. Daily, a score of 2. With every meal, a score of 3 is going to be given. Retrosternal pain, same as what we have in dysphagia. No retrosternal pain. Occasionally, retrosternal pain. Daily retrosternal pain, and retrosternal pain with every meal, score of 3. Regurgitation is also going to be same. No retrosternal, no regurgitation. Occasionally you see there is regurgitation. Daily there is regurgitation, and regurgitation after every meal, a score of 3. Right. So this is how the total scoring that you will do in an Eckardt scoring system. Higher the score, more severe the disease, right? So these are the components with respect to Eckardt's scoring system, right? So this is all that you should know in an extensive status of motility disorders. So look at the motility disorders. Now we started the motility disorders last week with this beautiful disorder and its the concept of achalasia cardia, right? So we went through the entire prospect of the achalasia cardia. We understood the physiology of the swallowing, what are the different types of contractions that we have. Then we spoke about what is the pathophysiology of achalasia cardia. We look at the clinical presentation, its complication, looked at the radiograph, manometric interpretation. This is a very, very important video. If you have not watched it, I would recommend you to go see how do we interpret manometry, especially if you are into your final year or if you are a resident first year. Both of them is going to be very, very relevant for your point. Then we spoke about how do we interpret it. Same thing we have just discussed in Chicago classification again. Management in extensive, surgical components we have taken care. Then we spoke about today diffuse esophageal spasm. We spoke about something which are lesser commonly understood disorders like hypertensive lower esophageal sphincter. Then we spoke about ineffective esophageal motility, your Chicago classification, and the Eckardt score of achalasia cardia, right? So this is what we have covered extensively in motility disorders of the esophagus. I promise you will not find anywhere else on any other place or any other component, or let it be YouTube, let it be free source, let it be a paid source. You will not find such an elaborate discussion anywhere. I request you to go through every single, the last three, and this is the fourth video, to understand all the components of your motility disorders. So we have two videos on motility disorders, the one that we did last week and the one that we're doing it today, right? Now all these notes, the handwritten notes will be available in my Telegram group. It is called as the Surgery Guide. This is by my name, that is Dr. Sandeep Seeram Reddy. So if you have any questions, any queries, and for notes, just pin it across here. Clear? Concept type 2 see, in not everywhere we are going to go and measure a DCI, no? But DCI is only there when you're talking about increased contractile force. तब DCI measure करोगे. Clear, guys? Sure. So thank you so much for joining. If you have any questions, any queries, do reach us out. Yeah, thank you, Utpal. Thank you, Raj. Thank you, Ayan. Everybody who's there watching online, thank you so much for all the support. Tomorrow, we will start. We have finished the diverticular disorders. We have finished the motility disorders. Tomorrow, we'll talk about esophageal perforations. So, kal do jo lectures honge, that will be on esophageal perforations. We'll talk about both spontaneous as well as your traumatic and iatrogenic injuries and their management. Until then, thank you so much. See you tomorrow at 9 p.m. Good night. Bye. Take care.